Hi, my name is Caitlin Duffner. I'm a third-year physical therapy student at The Ohio State University. Go Bucks. I'm currently at Illinois doing a final capstone project where I'm working with adaptive athletes in wheelchair track and wheelchair racing. And so I've made a 6-part series. This is part 6, and it's called Bridging the Gap Between Physical Therapy and Adaptive Sports. So the purpose of the project was to provide physical therapists and physical therapy students with an introduction to adaptive sports to better treat the wheelchair athlete. The first 5 parts included the introduction and benefits to adaptive sports, wheelchair and basketball and push run racing intros, classification, and biomechanics. This is the last part, part 6, and we're going to talk about common injuries, injury prevention, and a case study application. I'm going to really try to keep it under like 20 minutes, but we'll see. The objectives for today are to review common injuries in adaptive sports, learn how to treat common injuries, review injury prevention for wheelchair athletes, and apply the knowledge during a case study. So some common injuries in wheelchair sports are overuse upper extremity pathologies. In wheelchair users, they're pushing their chair all day, and then they're pushing their chair in their sport, and they're doing ADLs, transfers, all of those things. Often they're reaching up onto higher shelves because things aren't very accessible all the time, and that doesn't really help things. So the shoulder, you're going to get a lot of strains, sprains, and tears there. Rotator cuff pathology is pretty common. Biceps tendinopathy is also common, as well as impingement and AC joint pathology. At the elbow, you're going to see a lot of epicondylitis because there's going to be a lot of pronation and supination going on. And then with the fingers and wrists, there's some acute traumas like jams and fractures, especially in basketball. Those are pretty typical. And then mononeuropathies are also common, like carpal tunnel and then cyclist palsy, especially in the racers. Other injuries can include integumentary injuries like blisters or pressure sores, especially with athletes that might have sensation issues. Blisters are just pretty common because you're using your hands on the wheelchair a lot. Other health-related issues include autonomic dysreflexia, especially for people with spinal cord injuries, neurogenic bladder, and UTI. Concussions are becoming a little bit more common. You can see in this picture, this woman on the USA team fell out of her chair and her head is on the ground. So that can be pretty scary. There's also, because there's so much equipment going on with the chair, there's also a big risk for injury there because if you were to fall out, you're not just going to hit your head on the ground or on another person. It could be on someone else's chair. So I do want to have like a little bit of a disclaimer here that the treatment and diagnosis of upper extremity injury in the wheelchair user is going to look similar to the typical athlete, but there are certain biomechanical considerations from wheelchair use that are going to affect strength impairment and going to affect your treatment considerations. So it's just going to give you something to think about when treating these types of athletes. So this presentation is going to focus on supraspinatus impingement, long-term shoulder health, tendinopathies, carpal tunnel, and cyclist's nerve palsy. I don't want this to be like like an MSK course where I'm just like teaching you what it is, what the impairments are and how to treat them. It's going to be a little bit less in depth than that because I think that people have already seen these injuries before, either in the clinic or in lecture. So we'll start with the shoulder. It's the most commonly reported area of injury and pain in wheelchair users and Paralympic wheelchair athletes. Incidence ranges widely, but it can be up to 76% of wheelchair athletes, which is pretty significant. Overhead sports like fencing, basketball, things like that, can increase the risk of rotator cuff tear in individuals with spinal cord injury as well. And then the high-risk sports are basketball, track, road racing, throwing, fencing, and rugby. I'm not up to date on all of these sports. I'm really only, my knowledge is mostly in basketball and track. So some contributing factors are just the anatomy of the shoulder is pretty unstable. And then wheelchair users are using it for repetitive weight bearing, which is not its true purpose. They're also at higher risk for impingement because you're pushing your chair, you're really getting into that abduction, extension, and internal rotation. So you're just asking for impingement in that position. And then you're trying to put weight through it there or try to push your chair through. So you're just kind of asking for impingement at that point. It also doesn't help that sitting in a chair can lead to poor posture. So your forward head, shoulders, and scapular protraction. So you're really closing down that space in there and then adding like an impingement moment to the shoulder. Athletes are also at high risk for biceps tendinopathy. If you think back to our lecture about biomechanics, you're getting a lot of shoulder extension, and a lot of athletes just kind of dump their humerus forward. So you're getting a lot of anterior humeral head migration, and that's going to put a lot of stress on that biceps tendon and can lead to tendinopathies. You also have to think about with people in wheelchairs, a lot of times they're going to have a lack of a stable base. So their trunk support might not be the best, especially with people with spinal cord injuries. So that decreased trunk control is going to affect the joints down the chain. If you don't have a strong base, you're asking a lot of your shoulder. That lack of a stable base can also contribute to falls because you're not as steady or your balance might not be as good. So you can have like an increased risk of like a Fuchs injury or something like that. So there are some strength imbalances in wheelchair users. A lot of times you can see decreased adduction strength, rotator cuff strength, scapular retraction strength, and trunk strength. Something interesting that I didn't really know before I started this was that there's an increased abduction to adduction strength ratio compared to able-bodied people. So people who are wheelchair users often have high abduction strength, but they don't have good adduction strength. And the adductors and rotator cuff prevent that superior translation of the humerus, so that the humerus can start to ride up, and then you'll get that risk for impingement as well. The rotator cuff also controls the upward thrust of the humeral head during wheelchair propulsion. So that's super important. That's like every single day you're putting stress on that rotator cuff if you're not strengthening it. Oftentimes, the strong muscles in wheelchair users are the biceps, pec major, and anterior delt. So that's going to be a lot of that forward or that anterior musculature. And so if that's tight, that can also contribute to anterior humeral head migration and then biceps tendinopathy, as well as poor posture and putting you at risk for impingement. There's often also an increased push to pull ratio. So that basically means that people are pushing in their chairs a lot of the time. So like in typical weightlifters, the push-pull ratio is like you're benching too much and you're not doing enough deadlifts, enough lat pull downs, enough rows, things like that. So that ratio can be off, but it's the same thing in wheelchair users. If you're just pushing forward all the time, your anterior musculature is going to be really strong and maybe tight, and your posterior musculature might not have the same strength. So it's important to kind of normalize that ratio, make sure you're incorporating posterior musculature into your training. So as far as treatment goes for the shoulder, you want to obviously fix the strength impairments. So strengthen the rotator cuff, adductors, and scap retractors. Like I said before, rotator cuff and adductors are going to prevent that superior translation of the humeral head. And then middle and low trap strength to improve scapular retraction and stabilization as well. You're going to want to improve mobility via stretching. You can do stretching, manual therapy. A lot of times that anterior shoulder musculature is going to be very tight. And then once you get that mobility, you want to improve your strength throughout that range. I think that component is kind of left out sometimes in PT. But in athletes like this, they're using a lot of shoulder range of motion. And so you need to make sure that they're strong throughout that whole range, not just like the easy parts. And then another thing is going to be important is dynamic trunk control. Just really optimize that kinetic chain. You really want a stable base so that your shoulder doesn't have to do as much work. Postural interventions are always a go-to, especially sitting in a chair for a long time. Your posture is going to suffer after a while. And then in education, I think this part that is something that I kind of forget about, especially when I was working in inpatient rehab, the importance of long-term shoulder health. I sometimes kind of left that like the shoulder to the OT And I was like, I know so much about the shoulder. Why am I not implementing like a long-term shoulder health program for my patients that are likely going to be in a chair? So that's something that I definitely could have done better in the inpatient setting, and something that you can definitely do in the outpatient setting as well. So here are just some examples of exercises. I'm not really trying to reinvent the wheel. Obviously, you can do all of these exercises sitting down with TheraBand. I tried to use a lot of TheraBand exercises, so they're a little bit more accessible. But I think the important thing here is to really start in this neutral position when you're doing strengthening, and then work up from there. So we're starting neutral here and then working up to that 90-90 position, especially for people in wheelchairs because they're reaching all the time. If that's an issue for stress, you want to start lower and then work your way up as you gain strength. Same thing here with internal rotation strength. We're starting low at a neutral position. Something that I learned in the clinic is not really doing internal rotation lying down, because you're going to be lying on an ouchy shoulder. And so that's just something that I kind of stray away from. I'll just go straight into this internal rotation strength, or start with an isometric, so you're not lying on a hurt shoulder. And then moving into the 90-90 position once this is pain-free. Another thing is rotator cuff endurance. That's kind of the whole point of the rotator cuff. It doesn't need to be really, really strong. It needs to be strong over a long time. So working on endurance is going to be important. This one with the TRX can be adapted for athletes with lower extremity pathology if you put them on a bench and kind of scooch them towards the front of the bench as much as they can, and then get into this plank position. So their lower extremities can be supported either on a plinth or on a bench. And then you can also add perturbations as they get this position down and are a little bit more comfortable. So you can move like the ropes. So they're getting some perturbations there. So more exercises. These are kind of the go-tos, the ISTs and Ys, and then doing them with TheraBand. But these are pretty important because scapular retraction isn't something that you're using a lot with wheelchair propulsion. And so you're really, in order to prove that push-pull ratio, these are going to be your pull exercises. And then the last ones here are shoulder adduction exercises. Like I said before, the adductors in wheelchair users are often weaker than their abductors. So that might be something that you really want to work on. And then last thing here are thoracic mobility, lat mobility, and then shoulder flexion. So these are all good exercises to implement, especially when you're getting athletes that need to have a great shoulder range of motion, a big shoulder range of motion. So you want them to be mobile. So working in these mobility exercises and then strengthening in that mobility is going to be a good idea. And then we've got some thoracic stability exercises. Some people might not have the trunk control for these, and that's okay. But putting them in different positions to kind of challenge that is a good idea. And so here's a rehab protocol. It's the only one that I found for wheelchair athletes. And it's pretty good. It's kind of generic. So you might have to get more specific with your specific athlete and their specific impairments. But they break it down into 3 phases: acute, maintenance, and performance. So in the acute phase, there's lots of stretching and then strength exercises in neutral sort of positions. You're getting a lot of internal, external rotation, prone tees, things that are pretty easy that aren't going to be painful for the shoulder. And then you move on to the maintenance phase when everyday wheelchair use is pain-free. I think that the jump from acute to maintenance in these athletes is kind of hard. It's just tricky because they need their shoulder to just get around. They're independent because of their shoulders, basically. And so I think it's hard to get from that acute phase to that maintenance phase. Some things that I've seen are using like assisted mobility chairs, trying to limit transfers, especially like uphill transfers. but there's not a lot that you really can do unless they have someone with them that they can ask for help, especially with like reaching things and things like that. But I think that there's not a lot of research in getting from that acute phase to that maintenance phase, and we could really do better as like a whole to just put a little bit more effort into that sort of like research and trying to figure out the best way to get from that acute to that maintenance phase. This rehab protocol also doesn't include isometrics, which is something that I do a lot of times with my shoulder patients, especially in that acute phase. So that might be something to think about. This isn't like perfect, but it's better than nothing. So so then you go into the maintenance phase where you're getting a little bit more strength going on and in more range of motion. And then the performance phase, which is just working on muscles that you're going to be using for chair use. So there's also a lot of tendinopathies that occur in wheelchair users. So biceps tendinopathy, we talked about a little bit at the beginning, that anterior humeral head migration, because you have so much tight anterior musculature, is going to put some stress on that tendon. Also in wheelchair basketball, you're getting a lot of like braking going on at the rims and changing direction. And so that braking force is going to put an eccentric load on that biceps tendon, which can cause some irritation over time. Another one is rotator cuff tendinopathies. So you're getting like superior humeral head migration because you have rotator cuff weakness and a lot of times adductor weakness, and scapular dyskinesis also doesn't help. And so you're going to have rotator cuff impingements a lot of the time, and even some rotator cuff tears with tendinopathies as well. So this is usually due to repetitive impingement from that increased abduction internal rotation extension moment during pushing. And then you can get rotator cuff strain due to repetitive internal and external rotation as well. So if that's not strong, then you might get some tendinopathies or issues there. The last one we'll talk about is epicondylitis. So in racing, if you think about the biomechanics PowerPoint, we're getting a lot of like pro and supination and a lot of gripping, especially of the gloves in racing, but of the chair in wheelchair basketball. And so that could cause some irritation in the flexor pronators. And it could be reinforced by sharp turns during basketball. So you're really, really gripping your rims and like putting some torque through your forearms. So that can contribute to some epicondylitis, either medial or lateral. So treatment for these tendinopathies, we're still not trying to reinvent the wheel here. There's strong evidence for prolonged isometrics, progressive mechanical loading, and heavy slow resistance. I included the CPG, the OSU CPG for tendinopathy down below as well. But you really don't want to stretch these. I feel like that's kind of how the research has changed, at least since I've known about PT. So we'll move into wrist pathology next. The first one is carpal tunnel syndrome. I will say that during my time at U of I didn't have any athletes with carpal tunnel syndrome. It wasn't as common as the research suggested, but I thought not putting it in here would kind of be a disservice because it is so prevalent in the research, especially in older adults who have been wheelchair users for quite some time. I'm working with college age students who haven't been in wheelchairs for more than like 20 years. So this might be more important down the road, but either way, we'll get into it. So with wheelchair use, you're getting that repetitive wrist extension and flexion in those extreme ranges of motion. So that's eventually going to cause flexor inflammation and eventually median nerve encroachment. So some risk factors are loading the hand rim with increased force, increased body mass, and increased push frequency. So some education tips here would be to make sure that the patient is aware of signs and symptoms and prevention strategies for carpal tunnel syndrome. A lot of the times it's easier to prevent it in these scenarios than it is to treat it after it's happened. So if you do a lot of education and like what that median nerve pathology could look like, then the patient is going to pick up on it a little bit quicker if that does start to happen, and really know how to treat it instead of having it for a while and then trying to figure it out later. So some prevention strategies for carpal tunnel are to use this semicircular recovery pattern. So that's here. We're coming in a whole circle, so your hand will drop down after you release the wheel. To decrease body weight, which is definitely easier said than done, especially when you have carpal tunnel syndromes. But the next one is to decrease push frequency. So you want long fluid pushes. You don't want short choppy pushes, because then you're going to get more pushes and you're going to have more repetitive stress. You want your wheelchair to be as light as possible. And then to move your access wheel, the access wheel farther anterior. So if you look at this picture here, you can see that his hips and axis aren't really in line. If you move this wheel anterior, then they'll be more in line and you're getting much less torque on the shoulder and the wrist during this. So some treatment strategies, especially in the acute phase, might be to perform neutral wrist transfers. So instead of transferring with a flat wrist like this, when you're getting a lot of extension, if they can, make a fist and then push off of that fist, so you're getting a neutral wrist position and you're not loading in extreme extension. Another strategy could be to limit the number of transfers, especially uphill transfers. So you try to get them as level as possible. Improve mobility of the wrist flexors and extensors, but without obviously stretching super hard into something that's pathological. Education, definitely, what we talked about before, educating your patients on prevention strategies, and that neutral wrist position is going to be really helpful. So the last one we'll talk about here is called cyclist palsy. This wasn't in the research at all for wheelchair athletes, but I was talking to some coaches and some ATs and strength coaches at U of I, and they said that their cyclists have a lot of ulnar nerve pathologies. So cyclist palsy is one of them, and it's that entrapment of the ulnar nerve near the tunnel of Guyon. So risk factors would include frequent loading of the hand rim in wrist extension and radial deviation. So you're really compressing here. And then, and that was common in push rim cyclists. I didn't hear anything about the basketball team with ulnar nerve issues, but it's definitely possible. And then they would treat these with ulnar nerve glides and then just hand and wrist strengthening. So you're getting that wrist as strong as possible. So some clinical pearls before I let you guys go are to strengthen the rotator cuff, the adductors, periscapular musculature, and then wrist flexors and extensors. It's all about improving that push to pull ratio during strength training. You spend a lot of time pushing in your chair and only going forward. So you really got to work in backwards propulsion and then middle and low trap strengthening. They're going to have really strong anterior musculature. You got to make sure that you're balancing out the back. Education is always key. So educating on carpal tunnel signs and symptoms, emphasis on long-term shoulder health. So all of those exercises that I included before, maybe incorporate those in a home exercise program to try and prevent pathologies, especially down the road. It's super common to get shoulder pathologies as you've been in your chair longer. And then proper transfer technique is something that you might not think about, especially with athletes who have been doing transfers for so long, but there's always like tips and tricks that you can give them. A common one that I've seen is using shoulder external rotation instead of internal rotation. So if you look at these pictures here, this bottom one, Duffy's really using a lot of internal rotation here. So you see his hand placement. That's common because it allows you to like grab on to the surface that you're transferring to, but that's a lot of internal rotation and might be some stress on the shoulder here. So trying to do this in external rotation might be helpful. Also during transfers in a closed fist, and to alternate like your leading arm. So you're not always transferring with your right arm in the front. You can kind of switch it up. I wanted to include some outcome measures here. There's not a lot of outcome measures for wheelchair users, but I didn't know about any of these before I came to U of I. And they might be helpful for for kind of baseline testing and then testing them again after they've had an injury. That might be an interesting way to use these tests. You can also just see how your interventions have progressed and how they're helping your patient, or if they're improving or not. Obviously, you can always use the DASH, but there's some wheelchair specific skills that could be incorporated as well. All right, and we'll wrap it up with a case study. So in this scenario, you're a PT working in an outpatient neuro setting. Your patient is a 16-year-old male with a T6 incomplete spinal cord injury. His progress is plateauing, and he will likely be unable to ambulate without significant assistance. He presents with depression symptoms, decreased quality of life, and lack of interest in rehab. His main goal is to walk again. So my question here is, how could you incorporate adaptive sports into rehab? So feel free to pause it if you really want to think on it, but I'm just going to go ahead and do my spiel. So my first thing I would do as a PT in this situation is to really find out what his interests are, especially because he is presenting with depression symptoms, decreased quality of life, and he's not really interested in rehab. So I really have to put in the work and make this something that's worthwhile to him. So finding out what he's interested in, finding out what he doesn't like about PT or what he does like about PT, all of those good things. So you find out that his interests are in basketball. He's never really played, but he's really interested in like the NBA and he follows it and things like that. Another go-to would be to educate. So especially here, you have an individual with a really fresh injury. That's terrifying in all accounts. And so trying to connect him with people who are in a similar boat is going to be very helpful, especially as a PT who you might be an able-bodied person. And so connecting with him on his injury is going to be difficult. As much as you can try, you're never truly going to understand him. So trying to find people that are similar to him and that he can really bond with, it was going to be important. And so that can be done through adaptive sports. So educating him on adaptive sports options, connecting him to local leagues is going to be important. The benefits of sports and community, really trying to light a fire under his butt, maybe if he's not really too interested. And then emphasizing the importance of long-term shoulder health and getting him a home exercise program that is going to focus on rotator cuff adductors, posterior musculature. So he's really setting himself up for success in the long term if he's going to be using a chair. And then if he is into basketball, incorporating his interest into training. So instead of doing just like seated balance where we're reaching or like doing a puzzle or whatever, you're doing like chest passes or shooting or dribbling drills. So you're getting that dynamic trunk stability and making it into a game. So it's not just kind of boring PT things. You can also incorporate some wheelchair mobility skills where you're doing forward and backwards pushing as for cardio and for strength training. You can get some wheelchair skills in there too. That's all good stuff to do. All right, and then here are my resources. This clinical practice guideline of upper extremity preservation after spinal cord injury is really good. It's kind of long, but they do put everything into layman's terms. So I think that could be a really good resource for patients to give to them after a spinal cord injury. And this is the rehab protocol for the shoulder pain, which we kind of went through before. It goes way more in depth and gives some pictures of the exercises as well. And then this is also a good one, medical and musculoskeletal concerns for the wheelchair athlete. They kind of give like a holistic view, including like autonomic dysreflexia and things like that, and like UTI a little bit more in depth than I did in those circumstances. So that's a good reference or resource as well. And then here are my references. If you made it this far to the 6th PowerPoint and you listened to me talk for, I think like 2 hours now, I'm so proud of you. Thanks for listening. I really appreciate your time and your effort in looking at these PowerPoints. If you have any questions for me, my email is duffner, duffner.11@osu.edu. If you shoot me an email, I'll probably respond. I don't have a lot to do. All I'm doing is studying for boards. So But thanks so much for listening. If you haven't checked out the first 5 PowerPoints, they're pretty cool. If I do say so myself, they go into wheelchair basketball, wheelchair track, and biomechanics. So thanks so much for listening.